Welcome, everyone. Thank you for joining us. My name is Lily Jelinas, Editor-in-Chief for American Nurse Today, the official journal of the American Nurses Association. I'll be serving as webinar moderator. Our topic today is CFO-CNO Partnership for Workforce Management Outcomes, Benefits of Acuity-based Staffing, presented by an esteemed panel of experts. We thank them for their time and valuable information. This educational program is brought to you by GE Healthcare and Intel, working together to advance innovation and improve care efficiency through thought leadership programs like this one. We thank them for their support. To maximize your webinar experience, please take note of these important housekeeping items before we get started. First, the formal content of today's webinar will last approximately 45 minutes. The last 15 minutes will be reserved for questions. You can submit your comments and questions at any time in the text box on your screen, and we will address them after all presentations conclude. Second, a full recording of the webinar will be available within 72 hours, and all attendees will receive the link by email. The replay will be available on demand for 1 full year. You can access it free of charge as often as you need. If we run out of time and we're unable to get to your question, a contact name and email will be posted at the end of the webinar. Our plan for today is to discuss the partnership between nursing and finance executives to enhance clinical and financial outcomes, to identify the financial implications of using acuity-based staffing systems, and describe important next steps and resources to consider as you plan ahead. Now, meet our panel. Jack Needleman is the Fred W. and Pamela K. Wasserman Professor and Chair in the Department of Health Policy and Management at UCLA's Fielding School of Public Health. Syl Trepanier is Chief Nurse Executive at Providence St. Joseph Health, Torrance, California. Carlene Kerfoot is Chief Nursing Officer, GE Healthcare. So let's begin. Welcome to our first speaker.
Thank you very much, Lily. We have an exciting opportunity here today to talk about the challenges in today's healthcare system from the CFO perspective, and to make the point that it's partnership, it's partnership, it's partnership. We know that healthcare has changed dramatically in the last few months, and we know it's going to change even more as time goes on. There's a lot of moving parts there. It changes weekly, it changes daily, and it's our challenge to be able to adapt, and do what's best for patients, for patient care outcomes. So what we want to talk about is patient care outcomes. Patient care outcomes are extremely important to reimbursement. Patient care outcomes are extremely important to cost savings because we have to balance the outcomes with the cost. And all this is tied into RN engagement, RN retention, recruitment of physicians, recruitment of staff, recruitment of patients, so that we can provide the best level of service that is available in spite of all the challenges that will be ahead of us. We also know that more CFOs have become much more involved in the clinical aspects of care as of late, because so much of the reimbursement is tied to clinical aspects. We know CFOs are spending a lot of time with physicians, a lot of time on the front lines with the nursing staff, to be able to understand better when we make changes in the system how this is going to relate. So it's our opportunity to improve the business outcomes and to be able to really meet the challenges of value-based purchasing by creating the kind of value that people want for their patients and for their loved ones, also for their organization, for the staff, and to prevent things such as readmission, extended length of stay, better quality measures that will really be a difficult problem for us with risk-based contracts. So in summary, we have a huge opportunity today to talk about how CFOs and CNOs can work together better. The next slide talks about less cost and more value. That is our challenge. How do we get more value out of our system? Because people want more value, they want better outcomes, with less money, with less cost. And we know that that's possible because there is a lot of waste in the system and a lot of opportunity for us to do things better. One of the primary outcomes is labor cost containment, labor cost reduction. Now, that doesn't mean cutting, that means optimizing. And it means being able to flex up and down as patient needs indicate, and to also look at when mandatory overtime and things like that is necessary and when it's not. We know that anywhere from 40 to 60% of the healthcare organization's budget is in labor costs. And we know much of that is necessary, but we also know that we can optimize it much better through technology and things like that. So clinical outcomes are very important to us, and staff satisfaction is very important to us. And we know that the two are linked, and our speakers will be able to talk more about how those are linked. So as we think about it, all this works together as one. It's not separate silos. It's everybody working together as a partnership and as a team. On the next slide, let me talk to you a bit about some of the CFO's top financial concerns. Becker Healthcare asked questions in April of 2017 about CFO's top concerns. And one of the questions was, what are your top 3 financial concerns for your organization? What keeps you up at night? And this is what those 75 CFOs, health system CFOs, said. The thing that keeps them up at night is managing labor costs. 73% said that's a challenge. And they want to make sure they do it right and they don't do it the wrong way. Then also 71% said uncertainty about reimbursement. Well, it goes together. Reimbursement is dependent on good quality outcomes. Bad quality outcomes, your reimbursement is worse. And staying competitive in the market. Patient satisfaction keeps you competitive in the market. It also helps you recruit physicians, retain staff, gives you a great reputation for quality outcomes, as well as staff engagement and financial outcomes. So if we look at that, it's really important to think about what we're doing with all the staffing scheduling stuff that we need to talk about. And another question, where do you struggle with workforce management in your organization? So these people said, number one, ability to flex up and down based on volumes and patient needs. Note that they noted and patient needs, because they're very well aware that you don't flex just on volume. You have to flex based on patient needs also. And the challenge is, how do we know what those patient needs are? Another 47% said managing overtime and premium labor costs. And we can do that with predictive information and retrospective analysis. Leveraging staff across the entire enterprise. We can do that as long as we have technology that looks across the enterprise and can give us a real big picture of what's available out there. And staffing and productivity is a lagging measure versus proactive. We want to be able to get to the point where you know that if you make a decision like this, that's going to put somebody in overtime, and that will in fact be a problem for you. And finally, managing staff turnover and the cost of turnover. We know that turnover is not good for patient satisfaction, for patient quality, for the organization in terms of cost. We know all that. So their message is very clear that these are the challenges that we have. And finally, another question is, what about data? Are you using data elements to make staffing decisions? So if you look at it under staff skill competency, 37% aren't using staff skill and the competency. 28% are using it are in real time. And if you look at acuity, 31% are not using acuity. 25% have an acuity measure in real time. In the electronic health data, there is a lot of information about the patient in the electronic health information data set. 29% are not using it, 33% are using it retrospectively, and 37% are using it in real time. Admission discharge transfers, better in terms of 60% are using that in real time. In census, 79% are using that in real time. And that's the traditional way of being able to staff and schedule. So obviously we have huge opportunities to look at different data sets and to be able to get more information out of the system that's already there that we can pull together to optimize the way we staff and schedule and create excellence in terms of outcomes. So let's stop right here. We have a question. And the question is your organization currently using an automated acuity system that matches nurses with patients based on objective, accurate data from other systems? So if you can just type yes or no in the box there, and let us know if you are or if you are not using automated acuity system that matches nurses with patients based on objective, accurate data from other systems. So as you're doing that, let me introduce you to Dr. Jack Needleman. He's a professor and chair, Department of Health Policy and Management, UCLA Fielding School of Public Health. We are extremely privileged to have him with us today because he has all kinds of information about evidence that's been published, data that we need to use to really push us into data-driven staffing decisions. So thank you very much, Dr. Needleman, for being with us today, and take it away.
It is a pleasure to be here today to discuss the financial implications of acuity-based staffing. I'm going to begin the presentation talking a little bit about why acuity-based staffing systems and the factors that are needed to get the right staffing. Look at some of the criteria for assessing acuity-based systems, discuss a little bit about commercial versus locally developed systems, and spend some time on the business case for staffing, and try to answer the question, can we afford adequate staffing? The why is partly driven internally by the need to provide good quality care for patients, but it's increasingly being driven by external demands for appropriate staffing and staffing systems in place. We've got 14 states that currently address nurse staffing in hospitals in law or regulation. The big one, the headline one, is California, which specifies nurse staffing ratios unit by unit type. But in the other states that have done this, they basically have set up a system that requires hospitals to have a staffing system that and staffing committees that design appropriate staffing models for the hospital and assess whether the staffing model is being effectively implemented. 14 states with current laws, continued pressure to expand these, and a critical need to demonstrate the adequacy of staffing to the public and the staff in the hospital. And in this regard, I think one of the real issues is the fact that nursing is not often recognized as a core service of hospitals, but it is a core service. And the expectation of any patient entering the hospital is that the care that is at its core nursing care will be delivered reliably and keep patients safe. And what the research tells us is that when staffing is too low, either because there are too few hours of nursing staff available, or because we have the wrong mix, typically not enough registered nurses, patient safety is compromised. There's a substantial and growing body of research here. In 2007, there was a meta-analysis that was done by Robert Kane at the University of Minnesota that summarized the research that had been done up until that point. And what it showed is a consistent association between the presence of registered nurses, hours of registered nurses on a unit, and lower mortality, lower hospital complications. Those are all improved patient outcomes. Those do have some cost consequences for patients. Luckily, those consequences are rare in hospitals, and the savings associated with them, while significant, are not terribly large. But what the research has also shown is that length of stay is shortened when staffing is adequate, when staffing is higher. And since length of stay affects all patients, that has major financial consequences for hospitals. So patients don't care about financial consequences, but they do like the idea of getting out of the hospital earlier. Um, but from a hospital perspective, shorter length of stay means lower cost. Reduced complications means lower cost. And that's what the research has clearly shown to date. Um, some people say because so many of these studies have been done on comparing high-staffed to low-staffed hospitals, that maybe it's something else. Maybe it's not the staffing at all. My colleagues and I, in an article that was published in the New England Journal of Medicine in 2011, addressed this by using data from one large, high-quality system, which had some day-to-day variations in staffing that were not systematic. They were the random things people called in for illness, and the swing system didn't have staff to fully staff the system. And what we found when we looked at that is patients that were exposed to shifts with 8 hours or more below the target level of staffing that came from that hospital, they had higher rates of mortality. 2% increase in the mortality rate over the baseline mortality rate for every shift that the patient was on that had that lower than target staffing. So is it causal? Yes, it's causal. We have a number of different studies that have really illustrated that. One of the things that people have done to try to better understand staffing is to look at the issue of why staffing affects these outcomes. And one of the linkages that people have turned to and tried to understand is the role of nurses not being able to complete their work. Care left undone is one term in the literature. Missed care is another term in the literature. And what we see in hospitals that are staffed below levels that anybody should feel comfortable with is that the levels of missed care are quite high. In one survey of nurses in Europe, but this also, you see similar data from the US, nurses said we missed something. 87% of nurses said we missed something on our last shift. 52% of those of the nurses said we missed educating patients and their families. That includes preparing patients for discharge, and that should have consequences for unnecessary readmissions. Adequate patient surveillance, 35% of the nurses said they were not able to do that at the level that it should have been done on their last shift. And that too has consequences to these adverse outcomes that we were talking about. So I believe that miscare represents one of the clear pathways by which inadequate staffing leads to poor patient outcomes. And in other work that's been done, a very clear association of the level of staffing with the amount of care left undone. So low staffing and makes it hard for nurses to complete their work, which in turn increases the risk of patients staying in the hospital longer or experiencing an adverse event. So getting the right staffing is a critical challenge. And what we've learned from looking at the systems that provide staffing is that there are at least three dimensions to getting the staffing right. One is the patient need for nursing, patient complexity, their severity, whether they need transportation, whether they need to be observed, whether they have dementia or other mental limitations that require different kind of nursing and more nursing. So the patient characteristics are one of the critical issues in influencing what level of staffing is right. Second thing that's increasingly being recognized is that the characteristics of the nurse can be also important in establishing the right staffing. Skill mix is critical. I've talked about registered nurses compared to licensed practical nurses and nurses' aides. And I'll talk more about the effort to substitute LPNs or nurses aides for registered nurses later in the presentation. But figuring out what the right skill mix is for your patients becomes an important issue of getting staffing right. Nurse education and nurse experience, both overall and experience on the unit, can influence how efficiently the nurse can carry out their work, and can influence whether or not the staffing is at the right level or needs to be higher. And related to this are organizational factors, unit and organizational factors. So it's not just, is this individual nurse have a certain amount of experience, but what's the team on the unit look like? How stable is it? How mature is it? Is there patient turnover? Patient turnover adds demands to the nursing staff. The staffing system needs to take that into account. Support services and how they operate are critical. Are the nurses running around trying to collect linen? Are they the ones running around trying to collect the right drugs? Or are these kinds of supplies being provided by others influences what kind of staffing is needed? Support services or the work environment all influence outcomes. Patient classification systems should be including things like medications, education, psychosocial demands for patients, complicated dimension. One of the critical issues in systems is we want them to be parsimonious. We want them to be able to get the staffing right with minimal additional workload to enter data. They need to be based in expert nurse judgment. They need to be true reflections of the nurse's work. And all these criteria come into the decision about what system to use and how to implement it. There are commercial systems and locally developed systems, and there are pros and cons for each one. In general, the commercial systems tend to have higher data entry burden, although that's being mitigated these days by linkages to the electronic health record. Local systems really take into account the nature of the patients that are typically on units and the exceptions to those systems. So they can be built around a consensus model and can be adjusted to affect truly local circumstances. Here's one example of a local acuity model which deals with what kinds of procedures do the patients need, what kind of education do they need, what's the psychosocial status of the patients, and are there complicated IVs or meds that the patients need. Here's another example of a locally grown system which started out with a very simple grid system. We need on the day shift 1 RN for every 4 patients, in the evening and night 1 RN for every 5 patients, but there are exceptions to this. And the exceptions are specified for when we need an additional RN, and the exceptions are specified for when we need an additional PCA. And this system was driven by the charge nurses sitting down with the grid and saying, when do we need more staffing than the grid provides us? So it is possible to develop these systems. It's possible to develop them locally. It's possible to buy them and to get the staffing right. And that really brings us to the question of whether we can afford adequate staffing. And I think the critical insight into making the decision about whether we can afford is to consider not only the direct cost of the staffing, the labor cost, but the cost offsets that adequate staffing allow, from lower length of stay, from reduced adverse events, from reduced readmissions. And any analysis of the business case really needs to consider not only the direct cost of the labor, but these cost offsets. My colleagues and I developed such a business analysis in 2006 that was published in Health Affairs. Indeed, it was the most downloaded article in Health Affairs in 2006. That may feel like a long time ago, and since the work we did, the modeling we did has been duplicated and updated with new numbers and additional adverse outcomes. There have been folks who have used other methods like regressing the costs on increased staffing, on the differences in staffing levels. and they all come basically to the same answer. So for simplicity here, I'm going to walk through some of the data from our business case analysis. And what we found is if you raise the proportion of the staff that are RNs, this is an RN LPN model, you get more avoided days, length of stay goes down, you get avoided adverse outcomes, and you get avoided deaths. And similarly, if you raise the total number of hours, you get avoided days, reduced length of stay, avoided adverse outcomes, and avoided deaths, and one can do both. When we price these, moving every hospital that was below the top quartile up to the level of the top quartile, we priced this for the U.S. and we looked at their core staffing and their core costs. The cost of the higher nursing, just raising the RN proportion, dealing with that skill mix issue, was under $1 billion, and the avoided costs at full cost were $2.6 billion. So getting the skill mix right paid for itself. Having the proportion of RNs you actually needed, not trying to de-skill the labor force, paid for itself. Raising licensed hours, we're doing both, had substantial costs, but also pretty high avoided costs. And when we estimated what the additional cost would be, was in the range of less than 1% to 1.5%, depending upon what assumption we made. These are, I would argue, modest costs that can be afforded. And given the improvements in patient care, are appropriate to bear. The business case analysis, as I said, there have been other analyses that have been done and analyses that have been done by the commercial acuity system vendors. You will see similar numbers coming out from them. The ANA is currently working on a cost calculator for staffing. It should be available soon. It's based upon this research. It will produce similar numbers in aggregate and enable your hospitals to figure out what the effects of changed staffing would be for you. One of the critical issues in the business case is whether hospitals can retain the savings, and that depends on the payment model. Per discharge and capitated systems are most likely to allow hospitals to retain the gains. And as I said, one of the key messages from the business case analysis is getting the hours up to enable people to get their work done may cost a little bit more, but trying to save money by de-skilling the nursing staff, by replacing RNs with LPNs or other less skilled staff, are likely to increase the net costs, not save money. So some closing thoughts. As I said, nursing is a core service line at the hospitals, not just the core center, and should be assessed as a service line. Safe, reliable, effective nursing care depends on staffing at adequate levels to meet patient needs, and that is what patients expect when they come into the hospital. And systems, whether commercially or locally developed, can ensure more appropriate levels of staffing matched to patient acuity and patient needs. Thank you very much.
Well, good afternoon, everyone. This is Dr. Syl Trepanier, Chief Clinical Executive for Providence St. Joseph Health in the Los Angeles market. It gives me great pleasure to be spending a little bit of time this afternoon to review the importance of breaking down the silos. And what I mean by that is the importance of developing a relationship between the CNOs and the CFOs and how much more we can do together. I'll be also reflecting on the importance of leveraging a business case to support investing in an acuity-based system. Also going to be talking about the potential financial outcomes related to an acuity-based staffing model. First and foremost, I believe it's important to talk about the importance of developing that relationship between all of the C-suite. And in this particular case is the relationship between the chief nurse executive and the chief financial officer. I would argue that it's important to approach this with intent, not to expect the relationship to be developing with time, but rather to be deliberate, with intent, in developing that relationship. It's important to obviously be honest in that intent. It's also extremely important as you're developing any relationship with any colleagues within the C-suite, that when it's important and when it's appropriate to really compliment each other on the job well done. I believe that a thank you goes a long way, and recognizing each other is certainly very helpful. I would also argue that it's important to make the first move. Making the first move in developing that relationship, and also any conversation, if you will, where you believe you're going to be needing the assistance of your CFO in making that first move in that interaction. I would also argue that it's extremely important to respond and not react. I'm going to repeat this because this is very important. Responding versus reacting. Always check in with yourself, with your emotions, on how you feel about a particular topic as you're about to enter into this a conversation with your CFO, to ensure that you are demonstrating that you're responding to whatever the item may be, the conversation may be, and you're not reacting to it. In other words, otherwise would call it shooting from the hip, or even worse, shooting before you aim, which really can result in pretty bad outcomes, not to mention some casualty, no pun intended, when you do that kind of approach. I would also argue that the importance of, when you're developing that relationship, that it's important to demonstrate that you are interested as opposed to being interesting. So being interested as opposed to being interesting. So really demonstrating a deliberate intent in developing that relationship is really the key to foundation to working very closely with your CFO and any other member of your A-team C-suite, for example. The importance of building that relationship is that it also allows then to develop trust in one another, mutual respect. That really goes a long way. Being mindful of your presence, your executive presence, how you show up, how others show up, and really being demonstrating that mutual respect is very important. Welcoming diversity, and I think that becomes very important, in diversity really in its broad sense here. Not specifically to gender and to race, for instance, but really welcoming diversity in thought, diversity in where people come from, and how they were brought up to be who they were individually, personally, but also professionally, understanding that we bring something very different to the equation. And obviously open communication. When you have a great working relationship with someone, you can expect great communication along the way. So developing that relationship, you can expect those very five things. I would also argue that it's important in due time to also ask for help, and not to be shy of asking for help, to demonstrate that you know what you don't know, and really leveraging and asking the CFO to help you in your journey. Now, that said, I would also encourage and reinforce the fact that you shouldn't be making an ask on the very first meeting as you're developing that relationship. That's very important. It's also important to, as you get to know each other, to identify a common pain. And perhaps once you have identified that common pain, that becomes that very first thing that you work together on developing whatever it is that you need to develop, and working collaboratively together. I would also encourage to have the conversation with the CFO that perhaps there's already a model out there whether you're talking about a business case, whether you're talking about a pro forma, whatever tools that you might be in the process of developing to address whatever needs you may have. In this particular case, subject being developing a business case for an acuity-based system, to ask for a format that the CFO is comfortable with, or perhaps in your own corporation that is being used, so that you are already using the right language, the right format to move your agenda forward. And this is where that ask becomes very important. So as you have these conversations, as you develop that relationship, as you've identified that there's perhaps a need to implement an acuity-based system, for example, that the ask becomes, let me start working on developing that business case, and I would ask if it would be okay for the two of us to work together on this. Can I draft this, send it to you, and then you and I can discuss it forward, so that we are all on the same page. Some of you may be very well versed and in developing a business case, and good for you if you are. If you're not, I would tell you that that's a skill that you need to develop as a chief nurse executive. And there are a multitude of tools out there, some of which could be internal in your organization. And this is a resource that you may want to consider. It's part of the small business it's a governmental a website. It offers tools to develop a business plan. It's pretty robust. It's a free resource, and I've oftentimes shared it as a resource, and I find that many people find it very helpful. Here are 5 key elements that you need to make sure that you include in your business case. You need to make sure that you demonstrate a clear relationship between whatever it is that you're selling, in this case, an acuity-based system, and how does implementing an acuity-based system make sure that it supports the vision and the mission of the organization. I find that when you're selling this to whomever are the decision maker in paying for whatever it is that you're selling, in this case, an acuity-based system, that when you're tying the vision and the mission to what you're trying to do is always helpful. Be very clear about what the problem is. Be very clear about what the solution, and in this case, an acuity-based system being the solution for you. Be very clear about what the outcomes are going to be and how you're going to be measuring that. And as equally important, what's the value contribution? And the value contribution should help you tie all of this into the vision and the mission as well. Present the business case in collaboration with the CFO. So we talked about developing the relationship in advance. We talked about developing the business case together, and you and the CFO should be making the ask together. Now, understand that timing is everything, and sometimes making the ask right off the get-go might not be the right political move. So know your audience, and sometimes it's important to socialize the topic before you present the business case. You give chunks at a time, and then you just come at the meeting with no ask. I just want to share something with you. I'd like to socialize this concept with you, and then you come back again, and then eventually you come back with an ask, and then you don't have a lot of pre-sale to do because you've already done that in the past. And collaborating with your CFO becomes very important. Lastly, here are, in my opinion, some really tangible benefits of an acuity-based staffing once you've developed that business plan. Well, in some states, it enables you to meet the regulatory requirements. So good for you if that's a state where you might be residing. But it provides an accurate picture of the needs of the patients and the workload associated with it. In other words, objectivity. And that is key here, a key really operational outcomes of this. It supports individualized staffing plan that are based on patient needs, and it promotes a patient needs budget as opposed to a historical hours per patient day. And I believe that those are 4 very important benefits, tangible benefits of an acuity-based system. Thank you so much for your time this afternoon. And on this particular slide, there are some resources that you might find helpful. Thank you much.
Next on our agenda is to talk about operationalizing acuity-based staffing. It's one thing to talk about it, and it's another thing to see how we can operationalize it and make it really become real. We know that CFOs now are interested in the clinical outcomes. Jack has talked to us about a lot of the data that's available out there. Sil has talked to us about how to achieve all this with partnerships, close working relationships with CFOs and other people. And so the next opportunity is to really bring all that home to see how we can actually operationalize acuity-based staffing. So in the next slide, the point is we have data. We have data everywhere, absolutely everywhere. But our problem is that we don't have the opportunity of being able to synthesize it. And as you look at it, no human being can gather all that information and put it together in a coherent decision-making opportunity, because we're doing other things. Managers are staffing, managers are looking at quality, staff nurses are taking care of patients, and it goes on and on and on. So the point is we have lots of data, but we don't have an opportunity to really utilize it effectively unless we optimize it and bring it together so we can, in fact, look at what the patient needs. So let's start over in the right-hand corner with the patient need. We know that if we staff based on ratios, a patient is not a patient is not a patient. We know if we staff based on matrix, a patient is not a patient is not a patient. We know that within the matrix and within ratios, there's a lot of patient diversity. And within that, patients change. They are not static. They do one thing 1 hour, they crash and burn another hour. They do one thing 1 hour, they're ready for discharge in the second hour. So this is all very fluid. But the point is we have information in our systems to be able to pull out and to be able to get information about the patient. For example, the electronic health record has a lot of information from the nurse, from the assessment that the nurse does, from nursing documentation. We know a lot about patients that are high risk for falls. We know a lot about can they do self-care. We know a lot about their pain tolerance, their pain threshold. We also know a lot about the family. Do they have a difficult family? Do they have a very collaborative, workable family? We also know certain things that, for example, they're on chemo or they have to transition to another unit. We also know that they have a sitter. There's a lot of things in that medical record that give us an indication about how many nurses we need, what kind of nurse we need, what kind of assisted work we need, because it's right there in the electronic health record for us. So the point is we do have patient data. It's in a repository there, and we do have to look at it to make sure that we have data-driven, objective information versus an opinion that says, oh, this patient needs this. No, the patient does not need that. So as we move into evidence-based staffing and evidence-based ways of being able to work our units, this is what we need: evidence, data from the electronic health record. On the other side is the workforce. We know from lots of evidence that if certain patient needs are matched with the right nurse at the right time and the right place, then we have good outcomes. So we start with a patient need, find out what that patient needs, and then we look over in the workforce side to see who matches. For example, we know that we have credentials in that information somewhere. We know that somebody is credentialed to do oncology. So if we have a patient that needs chemo, we know that we've got credentials somewhere. We know that the person is credentialed to work in an ICU, so they can work in 2 or 3 different ICUs within the system. We know that this is what the unit needs. We know that we have ratios. We know skill mix. We know what their schedule is. We know all kinds of things. And the point is, as we pull out the information about the staff, then we can make sure that we have equitable assignments. A person who's been in the system for 5-10 years and is known as an expert nurse can take a different kind of patient. A person who has been there 6 weeks and is a brand new graduate who's working with a preceptor cannot take the same level of assignment and might not be able to for a year, sometimes even 2 years. So we have the information to be able to match correctly with what the patient needs. And then finally, at the top, a unit is not a unit is not a unit. Some units have a lot of admission, transfers, and discharge. Some have few. Some have a lot of new grads. Some are closed on the weekend, and it goes on and on and on. So if we look at the unit characteristics, also the layout of the unit, how far do people have to walk, we can be able to staff and schedule better based on knowing about those unit flow statistics and where people are. So it all starts with data. We have plenty of data, but we aren't using it effectively because we don't pull it out and we don't put it together. So the point is an integration. We want to integrate with chief financial officers. Chief financial officers want to integrate with clinical people. And we want to pull this all together based on the technology that we have so we can optimize what we're doing. So this depicts, the 3 areas we just talked about, which are, the patient data first that we can pull out. Then we can also pull out staff data. And we can also pull out operations data in terms of workflow, admission, discharge, transfers, and so on like that. So we can have a data-driven system, a data-driven workforce system that in fact gives us better information, more timely information, and we can then pull that together to create the kind of outcomes that we want. Well, the outcomes that we want is staffing optimization. So we know that if we optimize our staff, if we make sure that the most experienced person is working with the most difficult, complex patient, and that we have other people who we can pull in, such as pharmacy or whatever, as needed, we know if we can optimize that staff and have the right nurse with the right patient at the right time, then we can have much, much, much better outcomes. And so if we look at it, what Jack was talking about, and also Sil, is that we can, if we optimize the staff, then we know we have much better patient outcomes. Happy nurses, happy staff make for good patient outcomes. Good staffing makes for good patient outcomes because we don't have mistreatments if we've got the right amount of staff. We don't have nurses going home saying, oh my goodness, it was a terrible day, I don't know what I missed. And so we have staff satisfaction because we've got staffing optimized. The experienced nurse is being challenged every day with the kind of patient that they need, and the new nurse is not overwhelmed every day because they're taking care of patients that they're not ready to take care of. And we know that staff satisfaction leads to patient satisfaction. But it's not just that the staff are smiling, the staff are satisfied and able to get their work done, and the patient knows that, so we have much greater patient satisfaction. And we know also that we have incredible financial outcomes if we don't have turnover, if we have people optimized to their highest level of being able to work at the level that they're at. And also we know financial outcomes are embedded now in quality outcomes, patient satisfaction, and so on. And if we don't have good patient satisfaction, good quality outcomes, then our financial outcomes are not nearly as good as they need to be. And we also have opportunities with operational efficiencies because we can look every day and say, what do we do tomorrow? How can we make changes? Because we've got dynamic staffing and we've got people in there who are looking at it absolutely every single day. So obviously we have great engagement, much better patient outcomes, much better financial outcomes, and much better efficiencies, which is exactly what we've been talking about today. Well, the point is we can't get there without data and technology and processes. As I mentioned, this is too much for one human brain to be able to absorb by themselves in a short period of time to be able to turn it around. So data isn't good enough. What we have to do is we have to have the kind of technology that provides us, that synthesizes the information and sends it to us so we can look at it and we can say, oh, this is right on, or no, we need to tweak it a little bit. So our opportunity is to really look at the technology and the processes to be able to get to that. And we can really synthesize things as long as we've got the technology to look at it. We call it intelligent staffing, smart staffing, Because if we have these kind of tools in terms of data and technology to pull it out, we do in fact have intelligent, smart staffing. So let's walk through the process of staffing and see where we're at to be able to ascertain, are we where we need to be? First of all, if you have intelligent staffing, if you've got smart staffing, you start far out. You start 4 to 8 weeks ahead. You look at any kind of predictive information you have. You look at your seasonal acuity, because you probably know that, 8 weeks out or 10 weeks out, whatever it is, maybe you have more elderly people in that time of year because you have flu. And so your acuity data can help you look at that and create more realistic schedules than what you can otherwise. And again, it really looks at equity. How can you make sure that we've got people who feel good about their holiday schedule, who feel good that they're not having to be pulled in and last minute overtime? Because the better our schedule is ahead of time, then the less chaos we have at the end. And we really do want to take the chaos out. So if we create the schedule ahead of time based on lots of information that we didn't have before because we've got good technology, then the next thing we go to is open shift management. So if we look at the schedule and we say, well, there's some open shifts here, this is where we really get into collaborative staffing and collaborative relationships with our staff and with everybody else. We want to make sure that we have visibility across the system so that one person can look at what's available on another unit in case their unit isn't busy that particular day. And we can also look at the whole enterprise so we can be able to best optimize our staff. If one ICU isn't busy, then perhaps another one is very busy. So that person can sign up for that ICU and then we don't throw that ICU into overtime. And it's good opportunity, good experience for people to be able to do something different. So everyone really, really wins. Morale goes up and we've got people who are openly thankful that they get the opportunity to look at some other places. Then, the most important thing is that we do inter-shift adjustments. We know that many patients change within that shift. So if we staff just based on midnight census, it never works out. If we staff just based on matrix, it never works out. Because if you can add a staff, if you have 4 more patients, then you've got 3 patients that are underserved at that point in time. So what we do is we bring information across, we have to bring information in to be able to give real-time information. So if the patient gets worse or better, it comes across. One of our healthcare systems CNOs said this: we use data. Information from our EMR is fed into our Acuity system every 2 hours, and staffing is adjusted every 4 hours based on this data. Managers monitor nurse-patient assignments routinely as well as staffing multiple times a day and make adjustments. So with information flowing in on a regular basis, we have the opportunity of making intra-shift adjustments. If there are a lot of discharges, if there are a lot of admissions, if the acuity goes up and down, we know that and we can make intra-shift adjustments because we are doing data-based staffing, data evidence-based staffing. And finally, we have the opportunity after the shift to really look at what we're doing. Many people call it the rear view mirror approach. Because what we often do is we just staff and schedule and then we don't do anything else. And we do the same thing the next day and the next day that we did today. However, with this data and the analytics, we can look to see, oh, we really did well, or no, we didn't. We have the opportunity to look at retrospectively nurse assignment and maybe mistreatments, or nursing assignments and patient errors. And we have the opportunity to really look retrospectively at, the budget. Did the budget match what we saw that day? And is the acuity much higher? And what's the trend in that? Have we admitted, has a new physician come and he's admitting patients with more acuity or less acuity or whatever it happens to be? So we have the opportunity with the post-shift analysis to work with finance, to work with physicians, to work with everyone to really look at what we're doing and say, hey, we did it today, tomorrow here's an opportunity, because we know there's always an opportunity. And there's always opportunities when we can work collaboratively with other people to look at the same information through many kind of different eyes. So huge opportunity in these 4 stages based on data and based on information that comes over that's optimized to give support for a lot of decision making that we haven't had in the past. So let's stop here for a second and let's ask another question. Here's another question. Is your organization at a beginner, intermediate, or advanced level when it comes to understanding the impact that data-driven, evidence-based acuity has on clinical and financial outcomes? So if you could please type A, B, or C in the field that will give us a much better opportunity to be able to see what you have to say, that would be good. So take a minute now and please answer that poll question. Do you think that you're a beginner, intermediate, or advanced? So let me wrap up some of the things that we've been talking about. We all agree that CFOs and CNOs face many workforce challenges now, and it's going to get even more volatile in the future as we look at a healthcare system that will be full of challenges and full of changes. We know that clinical and financial partnerships is the only way to weather the storm, and that means partnerships with our frontline people, with our CFOs, with the executive suite, with everybody, because it does take a village, and people who have different perceptions do much better. And finally, the evidence shows that acuity-based staffing is effective. We have information from our two speakers that it's very effective, and so our challenge is how in the world do we make that happen so we can do a much better job of getting the outcomes that we want. It's all about partnerships. It's all about putting the patient first, and it's all about making sure that the patient needs can match the staff competencies and can be delivered in an opportunity where we have excellence in environment and excellence in partnerships and excellence in patient care. So to sum it all up, we have the opportunity to involve ourselves in smart systems now. We don't have to depend on opinion-based staffing, opinion-based things anymore, because we have smart systems. We have intelligent staffing systems that can analyze a lot of data and bring it to us. And of course, we have the opportunity for much more collaboration than what we did in the past, because we know we are all in this together, and we're all in this in terms of being able to get the best patient care outcomes that really work for our staff the best way possible and for our organizations. So in summary, it's all about partnerships, and it's all about starting with the patient first, and we certainly have the opportunity now to do that with the technology and the evidence that we have. Thank you.